webinar series that focuses on the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in treatment of chronic pain. This series is one of the many resources made available by the Prescriber's Clinical Support System, Opioid Therapies, a program that is funded by the Federal Center of Substance Abuse Treatment and operated collaboratively by 6 other partner organizations. These include the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. Just a few quick housekeeping notes before we get to today's presentation. In the upper right side of your computer screen, you'll see a control panel. In the lower portion of that panel, you can type in a question or comment and submit it to the webinar organizers. You can do that at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. And if we're unable to get to all the questions in the allotted time, our presenter has agreed to respond to them in writing. The webinar, presentation slides, and the questions and answers will be posted on the PCSSO website in the near future, as well as the INSA website. Today, Colleen LaBelle will address medication-assisted treatment utilizing nursing care managers. She will describe the role of Data 2000 in the treatment of opioid dependence, list the barriers to treatment of buprenorphine as a partial agonist, and finally describe the role of nurses in integration of office-based outpatient treatment in outpatient office-based opioid treatment in outpatient settings for example, in office patients with buprenorphine in an office-based primary care clinic, which manages over 450 active patients with buprenorphine. She's the program director of the state OBOT-B, which is the State Technical Assistance Treatment Expansion of buprenorphine. There she's working with 14 community health centers, implementing a nurse care manager model for the expansion of buprenorphine, and supports additional health centers and community settings with training and technical support. Since 2003, Ms. LaBelle has served on the faculty for buprenorphine certification course of the American Society of Addiction Medicine. She frequently consultation and technical assistance on and off-site and by telephone. She oversees the MDPA level, and Ms. LaBelle has also served as a member of the Scientific Study Section Review Committee for the National Institute on Drug Abuse. Since 2004, she served on the National Advisory Committee on Buprenorphine for the Health Resources and Services Administration and participated in professional editing of the TAP 30, which is the Technical Assistance Publication for Nurses, with SAMHSA in 2009. She has she's a co-author of 5-year experience with collaborative care of opioid-addicted patients using buprenorphine in primary care, published in the Archives of Internal Medicine. In May of 2001, she was the recipient of the Individual Leadership Award for Innovation in Healthcare from the Massachusetts Bureau of Substance Abuse Services, as well as an award recipient in 2011 for Innovations in Behavioral Health Services Award for Process Improvements. In 2012, she was awarded the Science and Service Award from SAMHSA. She's a board of director of the International Nurses Society Addiction Certification Board, and in 2011 started the Massachusetts chapter for addictions nurses and serves as the executive director of that chapter. In 2013, she was the recipient of the Mayor's Award for Innovations in Primary Care. So with that, I'd like to turn it over to Colleen LaBelle to begin today's presentation. Colleen, welcome.
Thank you, and welcome to all of you, and thanks for being here, and thanks, Deb, for that. I cut the person off because I'm usually in person, but I guess I have no choice when I'm on the phone. So welcome, and we're going to talk today about medication-assisted treatment utilizing nurse care managers and how that's an effective measure. Hopefully my, whoops, I'm having trouble advancing my slide. Oops, there it goes, sorry. So Deb spoke about the funding of this webinar series that is funded through SAMHSA, and this is just the information detailing that. I have no financial disclosures to report at this time, and these are the objectives that Deb also just laid out to you, that we're going to talk about Data 2000, the barriers to treatment, the use of buprenorphine, and the role of it, most importantly, in using nurse care managers to expand treatment. So across the state, we're all very aware of the fact that we're experiencing a public health epidemic, and that being from overdoses. But back in 2005, when we looked across the state, we were able to compare overdose deaths to those of motor vehicle accidents. And there were 10 states in the country, and unfortunately where we live in Massachusetts, we were one of those 10 states that more people were dying from a fatal overdose related to opioids than those that were dying from motor vehicle accidents. Even more disturbing is 5 years after that, being 2010, 31 states now have that same statistic. So overdoses are just continuing to increase, and we're continuing to struggle with this epidemic, which is now, as you can tell from looking across the state, is becoming a crisis in most places. So what we've had thus far, except with the utilization of methadone, has been typically detox protocols for folks where people could go inpatient. We know that the relapse rates and the retention when folks are being treated in an inpatient detox setting, unfortunately, are pretty low, in that there's a greater than 50% abstinent rate at 6 months, and then 12 months a greater than 15% abstinence, less than 15%. Remain abstinent. So with this increase in overdoses, we obviously need to look at more tools and more resources and how to expand treatment to treat this epidemic that we're all struggling with. We also know that when folks use opiates, that their tolerance decreases. So if somebody is using an opiate and then in fact stops using an opiate for a period of time, even that being 2 to 3 days, their tolerance is decreased, and so their chance of an overdose is greater. So say you're a person who's just coming out of a detox, or someone coming out of a residential, somebody who's not been using for 2 to 3 or 6 months, or someone that's just been incarcerated, comes out and they're back in their community and they pick up where they left off, their chance of a fatal overdose is much greater because their tolerance is lower. It's like someone who's opioid naive. So really important to, and a good friend, colleague of mine always talks about the fact that patients shouldn't use alone, and that patients should do tester shots, and we should talk to patients more about harm reduction and how to keep people safe if they in fact do use. So what we have at this point is medication to treat. If the person were in fact to use it, they wouldn't feel the effect of it, so they wouldn't want to be using an opioid. And to in fact try to change the chemical changes that have occurred in that brain. So the options we have to do this are those of naltrexone, being an antagonist, a drug that basically blocks the receptors so that if somebody were to use, they're not going to get any benefit. Methadone, being a full opioid agonist that we're all pretty knowledgeable about, and that being something patients can access in an outpatient opioid treatment program, that being methadone clinics per se. And then the third being that of buprenorphine, which is known as a partial agonist, and what we're going to speak about today. because of the change that has occurred. So before 2000, before the change in the law, you were not allowed to treat a person with opioid dependence in your office-based practice with that of an opioid. So what happened in 2000 is the Drug Addiction Treatment Act came along, which changed that law, which now made it so that physicians could in fact treat somebody with a drug that's FDA approved for the purpose of opioid maintenance or detox. That medication would need to be a Schedule 3, 4, or 5 and has to be approved for that purpose. You can't just take a drug and decide you're going to use this to treat somebody. So the act happened in 2000. However, the medication that would be FDA approved and that would fit this qualification didn't hit the pharmacy shelves and approval by the FDA until October of 2002. Methadone is a Schedule 2, so the rules and regulations that are surrounded around methadone maintenance remain as they have been. There's no change in that. The other pieces of this law, this rule that came about, is that physicians were only those who could prescribe this medication. So the drug has to be a Schedule 3, 4, or 5. It has to be FDA approved for the purpose, and it has to be prescribed by a physician. Nurse practitioners are not allowed at this point to prescribe this medication. So buprenorphine was the medication we're all very familiar with that falls under this rule. Physicians were also limited. First, it was 30 patients in a practice, so that meant if you had a federal tax ID number and you were Kaiser and Permente, you could treat 30 patients. Then it went to 30 patients per physician, and then following 1 year of practice by a physician with this waiver and this license to prescribe this medication, they can apply for an extended waiver. Now, it's really important to know that that's not automatic. Some physicians believe that once they've done it for a year, they can treat up to 100. They actually still have to apply to CSAT to get that extension. So they can treat the 30, or they can apply for the extended and treat the up to 100. So as long as those prescriptions are active under that patient, then that counts under their volume. Once that prescription, the refills are gone and the 30 or 28 days is over, they can take on an additional patient. But the physicians have to be waivered and get an additional DEA number, which we frequently call an X number, to prescribe this medication. And that medication, as we know it thus far, is buprenorphine. Buprenorphine is the only medication that meets these qualifications that's been FDA approved and that you can prescribe in your office-based practice. And so this slide just shows you, so the naltrexone, the full antagonist that somebody were to take, which just blocks the receptor, doesn't give any opioid effect. Then there's the partial agonist, that being buprenorphine, and breaches the ceiling, so more is not necessarily better. The person levels off, and it's going to help them potentially keep them from having an overdose because it's not going to fully attach to that receptor. Whereas your full agonist, the more somebody uses, the higher the receptor goes, and the more chance of overdose and respiratory depression. So how Suboxone buprenorphine, works is that buprenorphine has the ceiling effect. It sits on the receptor really tightly. It hangs out there for a long period of time. It has a long half-life. So if somebody were to be on this medication and they wanted to use and they wanted to get high, they'd really have to plan that. It doesn't mean they couldn't do it. But if they took their medication in the morning and that afternoon, they're probably not going to get high if they bumped into their buddy and decided to potentially pick up. So somebody can, in fact, stop their medication and make that, concerted effort to get high on the weekend and then go back on their medication, which, of course, is not very safe. So it sits on the receptor. It holds on tightly. So if somebody is on the maintenance medication and they do, say, use a bag of heroin, the only thing it's going to do is keep that receptor blocked. That heroin, even though it's a full agonist, is not as strong as the buprenorphine, and so it's not going to attach. It's just going to annoy the person that they just used and they didn't get high. If somebody is actively using, they crush and they inject buprenorphine, they're going to get the naloxone effect. So buprenorphine has another drug in the combination called naloxone. So naloxone basically will be the drug that's activated when it's injected, and if the medication is taken as it's intended to, and that is sublingual, then the buprenorphine is activated. So if somebody who's actively using doesn't potentially abuse this medication, but this medication can in fact still have street value for somebody who can't access it and is looking for treatment or is in withdrawal and can't access heroin or whatever opiate they may be using. So the goals for treatment for someone who's on buprenorphine is to prevent withdrawal, to prevent cravings, to prevent a relapse, to help somebody normalize the brain changes, take away the withdrawal and the cravings, and help them restore, their brain functioning and return to normal life and into their social being as they were prior to their substance use. So what happened in Massachusetts, we are very fortunate in Massachusetts, and I wish everybody was as fortunate, is we did a needs assessment, or the Bureau of Substance Abuse Services did a needs assessment where we looked and we saw, and as you saw back in 2005, we were amongst those five states that had more people dying from overdoses than motor vehicle accidents. So we had a problem really early on in this epidemic. And so the state saw that we had a high rate of opiate addiction. We had lots of fatal overdoses that were occurring. People were trying to access treatment, couldn't get into treatment. We didn't have enough treatment beds. Some people were being kicked in and out because treatment days were short, what the insurance companies were covering. There were long waits to get into medication-assisted treatment. We did have methadone, but there were always wait lists for methadone. And then as time marched on, when the medication became approved, there were wait lists for buprenorphine, and buprenorphine was really hard to access as well. Some people were able to access it from providers that may have not been taking insurance, and they may not have had the means to do so. And of course, people want what they want, and some people don't want to be in a methadone setting. Some people didn't want to go to detox. Some people just wanted that medication. It may be because it's easier. You can take the medication and go home, and not everybody knows your business. There's lots of reasons why this medication may be attractive to patients. But there weren't enough physicians. There weren't enough people doing this. There weren't enough waiver doctors out there. And those that were out there, some of them had small practices, or they were only treating a really small subset. They may have only been treating their patients, or they may have learned about a nephew who had it and it got them attracted to it, or had a patient in their practice, and they may only be treating that one person. So therefore, access was still a huge, huge barrier. So the state did this needs assessment and sent these surveys out to all the waivered physicians within the state. And at that point in 2005, there were 356 physicians that had been waivered to prescribe buprenorphine. When they did this, they got a response. 256 of the physicians responded to this, and 66% of them were prescribers. Another 34% were non-prescribers. And then they looked at, who they were prescribing to and why they were or weren't prescribing, and what the story was with that. But we also broke it down and looked at the physicians, what their discipline was, whether it was psychiatry or primary care. And so the prescribers, so it was pretty even that 50% of psychiatrists and 50% of you primary care doctors were prescribing. But again, a really large percent of people that were still not prescribing to patients. And when we then looked at what those barriers looked like, it was really interesting. And the barriers were that people lacked the support that they felt they needed to integrate this into their office practice. They felt that nursing support was a huge barrier, and office supports as well. So they felt like treating addiction in their practice was very complicated and required some additional resources that they may not have had. They may have been a solo provider, or they may have been in a practice where they just, they had to see a certain number of patients, and adding addiction, which we all know takes time and can be, complicated. It's not always that simple. Was not something that they felt that they could do on their own. Payment structure was an issue for some. Institutional support, some facilities didn't want providers treating addiction in their practice. And then a lot of that might have been connected to the lack of staff knowledge. People not understanding the disease, not understanding addiction, not feeling like they had the skill set. So there were lots of barriers, and most of the providers, were able to identify one or more barriers. Greater than 55% were able to do that. So when you looked at that, so if the barriers improved, 54% of those who had never prescribed buprenorphine would potentially prescribe. So this was a paper that was published in the Journal of Internal Medicine by Alex Wally and colleagues here in Massachusetts from that the barrier information that the state collected on our prescribers. So what we learned really quickly, and what we've all known all along, is that takes more than a physician to do this medication. The physician may be the one that can write that prescription. They may be the only one that can do that piece of it, but we need the whole team. We need the multidisciplinary approach. We need the nurses and the case managers and the counselors and the social workers and the psychiatrists and your hepatitis doctors and your HIV doctors and whomever else needs to be part of that, your pediatricians and your OBs, because family and children and pregnant women become involved in this as well. So the physician's prescribing, but bringing the team together is what's going to make this work, and not somebody just doing this out on their own typically. This is what the map looks like now. This is an update as of May of 2014 from CSAT, and this shows you how many physicians in each state are now waivered to prescribe buprenorphine. And these numbers have increased pretty dramatically. However, they're still not great. Even in Massachusetts, we have over 1,300 physicians that are now able to prescribe this, but in Massachusetts, we have 39,000 physicians. So it's still, access is still challenging. It's actually still very difficult for someone to walk into a practice and potentially, find somebody who's able and willing to prescribe buprenorphine to them. So how Massachusetts responded to this in a few ways. We did a pilot at BMC, and then the Bureau went ahead and they put in 2 RFRs out there to basically fund nurse care managers, because they saw that that looked like a piece that they could really sink their teeth in to make an effect. And we actually started doing it at BMC earlier on, so they saw that it was working. So they funded nurse care managers in these community health centers, so in people's neighborhoods, to facilitate program development in the community health centers. They also funded some training and technical support to then support the community health centers and to support the state in implementing this treatment model. So what does a nurse care manager model look like? And it looks a little bit different everywhere you go, but typically how we've implemented in the state of Mass is that the nurse or a screener does that initial screener on the patient. Then the nurse sees the patient. The nurse does that intake. There's a counseling component that's added to it, and I'm going to go over each of these in more detail. The intake happens typically by the nurse, but in some situations the MD, or in combination by both, and the physician visit, and then there's the induction, the stabilization, and the maintenance that happens. And we're going to break those down. So in the screening that happens, the screening is important because, a patient may be calling up feeling like this is what they want to do and this is what they want, but it may not be the right treatment of choice for that patient. So in the screening, you want to talk to patients and try to get a history of their substance abuse, what their treatments have looked like, have they done any inpatient, any detox, what's worked, what's not worked, so that you get a little bit of an idea of, where you may be headed. And it may give you some guidance, but it may not. The other is the medical history. So, you want to know, is your patient got pending surgery? So is pain going to be an issue? Is the patient got advanced hepatitis C and their liver functions are really, really high? And is this really the right medication for them? Are they presently pregnant? What's their mental health history look like? Are they on medications? Have they been prescribed medications? Are they taking their medications? Are they mentally stable? Are they schizophrenic and not able to take their medications because they live under a bridge? Are they schizophrenic and they live in a program and somebody administers their medications? So that person who's schizophrenic living under the bridge may not be a good candidate for office-based practice because you need someone to help them take those medications, but that person who's schizophrenic living in a supportive program may be a really good candidate for this medication because they have somebody who's going to assist them with that part of their treatment, which is really important. What are their social issues, social supports look like? Do they have family? Are they housed? Do they have recovery systems? Can you bring any of those supports in to help the patient in this process? And so the more supports and the more resources you have, typically the better a patient is going to do. And some of our patients still have really good support, so try to engage them in the process because this is a family disease is really useful. So what are their goals for treatment? And we all have our objectives and where we're headed, but it's kind of important to know what the patient wants, what they're looking for, what they hope to accomplish in this relationship that they're going to engage in with you. So then we collect that information. The person looks like they're safe enough to be seen in an office practice. They're not acute, they're not actively suicidal or homicidal or have some psychotic disease that you probably can't really manage safely in your practice. So then we would bring the person in for an office visit to meet with the nurse. So the nurse does and collects all of this upfront information so as to ease the burden on the other end by the physician who's already busy with another whole entire group of patients that they're managing. So the nurse does that initial intake, reviewing their medical history, their pain issues, their mental health issues. Again, going over data that we already got that may be different, and you don't always get the same story. We all know that. What their current use is. Has that changed from when you spoke to, what medications they may be on, what's prescribed, what's not prescribed, what they're using, what they're abusing. The nurse then goes over the treatment consent, so consenting to be on this medication, informing them that it is an opiate and you can become dependent on it, and then the treatment agreement, or the treatment contract as some people like to call it, so that everybody's on the same page, so they understand what's expected of them, and you understand, and you're letting them know what the program is expecting, so everybody can agree to either this works for them or it doesn't. I mean, you may be open Monday through Friday, 8 to 4, and they may work a job and they can't get there till 6. So that's not going to work. So try to make sure that your program meets their needs and vice versa. Providing them with education so the nurse can sit with them and explain to them about the medication, how it works, what the medication looks like, how they're going to take it, that sublingual administration, which can be very challenging, that it is an opiate, the safety of the medication, where they're going to get their medication, when they're going to get their medication. Those are always really big questions for patients. Urine tox screen. So we do a urine tox screen at that initial visit. So a patient may tell you that they only use heroin and the urine screen comes back with benzos and amphetamines and cocaine. You need to kind of figure out, what's going on here. Is the person getting, benzodiazepines from somebody else and Adderall from someone else, or are they abusing them on the street, and how often? And is this a patient you can manage in your practice? Does the person need to go to detox? So trying to sort through those things. And then lab functions, and again, this may be very specific to certain practices. There was a lot of talk about doing liver functions in the beginning, but it looks like that may not always be totally necessary, and that the liver abnormalities we're seeing don't seem to be as problematic. Hepatology screenings, we do liver function on everyone, and we check Hep A, B, and C if we don't have recent ones in our chart. We check for syphilis, we do a CBC, just for routine results, so we have a sense of where we're starting, and a pregnancy test on every pregnant woman. So again, we do the pregnancy test routinely at start and then intermittently while we're managing them, because women, we are treating a younger population and they often do become pregnant. It's really important that everyone's on the same page, that everyone's working together, and everyone's sending the same message, from the person who picks up that phone when the person calls to the nurse and the doctor that are seeing the patient. We can't be splitting. We all have to be sending the same message, talking to each other in the same language, and working together as a team to help that patient. And so the patient understanding the rules, you understanding what the patient can do, making the patient part of this. This is their treatment. If we don't develop something that works for them, it's not going to work. And behaviorally, letting them know that behavior is part of the treatment, letting them know that counseling is a component. And with our treatment, we require some form of counseling, at least in the start. And then as folks progress, that may not be a mandate, but typically it is in the beginning phases. So once the nurse sees the physician, the patient sees the nurse, they put all that information together. And then the patient then sees the physician at probably another day or the following week or what have you, who gets to review the history, has all of that stuff in a nice, neat package already hopefully integrated into your electronic medical record, where they can review the mental health, substance abuse, the medical, the social, the physical, what we got for their drug history, what they're actively using, what medications they're on, that we've done the education and the treatment agreements and the consents with them, and they can review the lab results. So a lot of that, it saves a lot of time on the physician end. It is really important, though, for the physician to still meet with that person and to do the physical exam and to confirm that that person does, in fact, have an opioid dependence diagnosis by criteria. So we may, like we always say, the nurses tend to get more information, and sometimes if they don't want to tell the physician something. But again, the physician does need to, in fact, be sure that that person is appropriate for treatment, has the criteria, and is appropriate for office-based treatment. So the physician confirms that and writes off on that, and then writes the orders and the prescriptions for the medication that the patient will then be managed on. And that's the upfront piece of it. So once all of that happens, the induction process begins. And so for that, appointments and what have you were set up. We review the process with the patient, so we want to make sure, again, that everybody's on the same page. The patient understands the frequency of when they're going to need to come in, how often, who they're going to see, the times. The counseling component of it needs to be built in. That they're going to have urine screens, that's part of the program, that's part of us trying to help them in their recovery process. It's not always easy for someone who's been struggling with addiction to tell you the truth. So the urine gives us a tool that we can say, hey, there's cocaine in your urine today. Do you want to talk about that? Do you want to tell me what's going on? So you can then have that dialogue. It's not about catching them or about shaming somebody because they had a relapse. Letting them know that we are looking for abstinence. I mean, that is ultimately the goal, but we don't kick people out that are struggling in their addiction. We try to work on a harm reduction model, and then if this model doesn't work for them and it's not safe, then we may have to move them to another level of care. We talked to them about safety and about storage, and there's been a lot about this with this medication, especially when you see that now we've gone from the pill to the film, and the reason for the film is so that it's now packaged in something that's a lot more secure and difficult for children to get their hands on, because there have been lots of pediatric exposures, not just to this opiate but to others. But this medication initially came and it was orange, and it looked like candy, it's chalky, it's bitter, and what have you, and kids were getting it into their mouths. And as we know really quickly, that can be very problematic because of the way this medication is absorbed. So we actually put this brochure together, and I just threw it in here because if anyone's ever interested in it, we are more than happy to share it. We don't need to reinvent wheels. This work is hard enough. We have this through our clearinghouse in Massachusetts, but we give this to every patient who comes in. Just talking to them about the safety and storage and what to do, if a child were to get their hands on this medication, and the importance of calling 911 and the importance of the Poison Control Center. And again, very happy to share this. You can take the template, change it, or what have you, if anyone's interested. We were also giving patients locked bags that look like bank bags, and we were asking them to store their medication in this because we just didn't want it around. We didn't want kids getting their hands on it. Or keeping it in some type of a secure cabinet. So patients, unfortunately, struggle sometimes with taking this medication and how it collects all the saliva and what have you in the mouth, and they'll break the pill and maybe put half on the dresser while they take their shower. So really in educating patients about not doing that, and if they need to carry some with them, that they should get a second pill bottle from the pharmacy that has a child-proof cap on that to carry their medication, always in a labeled container that is child-proof. So we talk to our patients about their induction. Induction is really stressful. We're saying we're telling a patient to come in the early stages of withdrawal into our clinic. We want to make sure that everything goes smoothly for that patient. So we want to verify their insurance. We want to make sure that the medication is covered. They're able to get it. There's no prior authorization. They don't have this huge copay, and they don't have the money for it. So you want to work all the bugs out beforehand. We want to talk to your patients about disposing of their paraphernalia, about getting rid of phone numbers and contacts and what have you, so that they can start with a clean slate if they're willing to do that. That they then have to go to the pharmacy and pick up the medication prior to coming. So when we do this with a nurse care manager model, when we do inductions in the office, the patients go to the pharmacy, they pick up their medication, they bring it to the office with them. We always want to instruct patients not to drive or do things that could cause them harm until they're sure how the medication works for them, and encouraging people to bring a support person if they in fact can do that. You also want to talk to patients. Some patients will stop using the heroin because now they don't want to be on the street. They're trying to do the right thing. They bought some Dolphins and they're using that for the weekend. So making sure what it was our patients used before we start an induction so that we don't precipitate withdrawal, because if somebody was using Dolphins and they come in to see you, that's going to look a little bit differently than someone coming off of a short acting. So this builds a lot of trust. Nurses are really good at building trust and building relationships with patients, but we're asking our patients in Boston, at least, stop using on Sunday night, get rid of your drugs, your paraphernalia, your phone numbers, take your 2 buses and a train and come sit in the waiting room and wait for me to call you. So that's a lot. I mean, I know it's gotten easier, and our patients are probably better at doing inductions than we are and know how to do this and how to do it well. But there are definitely those that don't have that same safety net or are worried because now they're going to take that next step into really starting on a medication, and they're really going to stop using the opiates. So you want to make sure your patient understands what to do and where to go, that they trust you, that you have that relationship, and that if you're not there, what to do. So working with your patient and educating and supporting them is really important. Giving them contact numbers so that what if you didn't show up on that Monday morning? Who do they call? How do they get their medication? And they always need to know how to get their medication, how to get their treatment. That's really, really important. I mean, none of us is invincible. Anything can happen. And so what happens when when you're not there? And how do they access their medication if it's a snowstorm or something? So the nurses see patients. They come in. We follow a protocol. The nurses never administer the medication. You're not allowed to do that. The patients bring their medication to the office. The patients have been seen by the physician. They're in the clinic with physicians that are seeing patients for other things. May see that patient that day, but may not necessarily see them, but we're following a protocol. So we assess the patient for the clinical opiate withdrawal signs, and when they're in that early stage of withdrawal, that we're able to objectively observe, then that person starts their medication and they're self-administering the medication per the protocol under the guidance of the nurse. And that's really important. I mean, you can't administer this medication. I mean, if you're in an inpatient setting and you have an order, yes, you can give the medication. If you're in an outpatient setting and you're, observing a patient, they're bringing their medication. They're taking that medication per the protocol, and then you're reassessing how they're doing. And when someone's going through withdrawal, I mean, they're not typically very happy, and they're, when you're asking them questions that they probably consider pretty stupid, you're going to get really dumb answers in response. I mean, you're asking them, how do you feel? How do you feel? And you're giving them these really dinky doses because we're titrating the medication, and we want to make sure that they don't have an opiate on board, so we're not putting them into withdrawal, and you want to make sure that they're not going to have a reaction to the medication. So what I always tell my nurses to say is, like, so when you reassess them that hour later, I do feel better, worse, or the same. Because it's really hard to sort it out. It's kind of like when you're having a flu or you're feeling sick or you just had surgery and everyone's asking you how you feel. We just want to make sure they're not feeling worse. That's the key here. So if the person's not feeling worse, then the titration, the protocol can continue. The person can be dosed again and then sent home with instructions to call the team. And that's how we work it in the outpatient setting. A lot of folks, they'll say, why don't you do this at home, and this is pretty easy, and patients know how to do this. Sometimes it's better to do it in the office because it gets the person started. It gives them that start point. It gets them out of the gate, whereas if you send them home with the medication, they may drag their feet for a week or so, and I'm going to party this weekend, I have this medication, and I can start it if I need it. So it just kind of gets them going and really puts everything out there to get their recovery in the works. This is just an example of what the clinical opiate withdrawal scale looks like. Everyone may use different tools. We have this tool actually integrated into our electronic medical records, so the nurses, as they assess the patients and go through these boxes, it calculates it, and then after they've gotten that first dose and they reassess them an hour or 2 hours later, they can go ahead again and do this, and it calculates it right into the record, which is really nice. So the nurses see the patients pretty frequently, at least in the beginning stages. They see them weekly and then less frequently as the patients stabilize. So as they stabilize, their urine screens become negative, their counseling is in place, things are getting better, then that decreases. And then, that can decrease from weekly to every 2 weeks and then to monthly or to random, again, depending on the patient's needs. Some patients may need to be seen more frequently. Some patients may need to be on weekly forever. And some people will tell you it's part of their recovery and it really helps them. And to remember, it's a chronic relapsing disease. And patients do well for a long period of time, they can potentially relapse. So it's important to be checking in, and we'll go through our list and go, oh yeah, I haven't seen so-and-so in a while, and give them a call, bring them back in. do a check-in, see how they're doing. It's important to remember the comfort measures. If patients are struggling with side effects or comfort issues and we don't address them, we're potentially going to lose them to a relapse. So really being aware, I mean, this is a pretty safe opiate. It's pretty well tolerated, but some people have trouble with, it could be side effects, it could be withdrawal that they're still feeling, they're having trouble sleeping, or they're anxious. Or they could have pain that they may not have been feeling before because they were using and now they're feeling pain. You want to pay attention to that because it could be something clinical. Do you want to follow your protocols? You want to consult with your physicians as needed. We have ours integrated into our medical records where our docs are very in tune with what's going on with the patients all the time, both in writing and then in person because they're in the clinics and we're able to grab them. So in the very beginning, scripts are written weekly, some with, some without refills. You can put refills on this medication. And as the patient stabilizes and the urine screens are negative and they're going to counseling and their life is getting into a better place, then that may go to 2-week scripts and may go with or without refills, and then they may progress to monthly prescriptions. We keep the patient's pharmacy information on file all the time so that if something's up, we don't see a patient, they're not coming back in, say somebody's on monthly and they have refills and we're calling them for a callback and they're not responding, we can pick up the phone and call the pharmacy and say, hey, can you cancel the refills on Joe Smith? We're not canceling it because we're trying to kick them out of care, and we make that really clear to our patients. If we cancel your prescription, we're trying to get your attention. Come back in. Let's regroup. Let's figure out what's going on and help you get back on track. So on nursing follow-up visits, our nurses are seeing the patients weekly. They're doing all of that, intense follow-up with the patients, which is really, really important, especially in the early stages of this disease. They're assessing the dose and the frequency at which they're taking it and how they're tolerating it, if they're having side effects, if they're having cravings, whether they're going to counseling. If there's something psychiatrically is going on, they may not have acknowledged anything psychiatric prior to this, but now that the other drugs have cleared, you may notice that the person's depressed or anxious or something's up that they need to be evaluated. Helping them get engaged in their medical care is another important thing here, and like I said before, assessing for pregnancy. And social stability, social supports are really good indicators of how well somebody's doing in their recovery. So somebody says to you, they're hanging out with their family again, they're living with their mom, they moved back in with their kids, those are good indicators. They're looking for a job, they just got hired. So it helps you gauge how well someone's doing. Kind of like if someone's on methadone, you say, do you have take-homes? If they tell you they have take-homes, you know that person's probably doing pretty well in their recovery. So we continue to monitor, and we monitor to help the patient in their disease, and urine tox is a great way to do that. We do pill counts randomly, or if there's a concern, we may need to do a pharmacy check-in or an observed dose. So if we get a call back that somebody's, that somebody's potentially selling their medication or that person's using, somebody may call you and give you some ridiculous call that you can't acknowledge, but you can bring the person in for a callback. Scheduled visits are good, but random callbacks and check-ins are usually more effective. And checking in with support systems, if you have consent to do that, is also a nice way, or them checking in with you. And again, it's not about ratting people out, it's about helping people and trying to, bring somebody back in before there's a full-blown relapse and maybe you can't get a hold of them. Utilizing your pharmacy, the PMP, the prescription monitoring programs, are now a great resource, and we're waiting for nurses to get on board as delegates in Massachusetts. Important to collaborate and identify one pharmacy for all meds if at all possible, and keeping that information on file. Keeping their refill history and other controls. You can put refills on a Schedule 3, but the pharmacist is also great when they pick up the phone and they call you and they say, hey, your patient's filling a perk script from some doctor at another institution and your patient's on buprenorphine and you didn't know that. So we always are very gracious when the pharmacists call and let us know this information, because it helps us take better care and try to sort out what's going on. If there's issues at the pharmacy, the patient's known they're always there harassing them, they're looking for the prescription early, they're acting inappropriately. Those are also good things to help you figure out how your patient's doing. Talked about this. Stability, so as patients progress in their recovery, you expect people to do better. Things improve. They're becoming employed. They're not getting incarcerated. They may be cleaning up old warrants, but their new things shouldn't be happening. They shouldn't be going in and out of detox. They should be getting some social supports. So abstinence is the goal. Some people, it's a harm reduction model, but we kind of figure out how patients are doing. If they're not doing well, we need to potentially reevaluate and regroup. And that involves the patient. The patient's really important here. So Dan Alford always says it's not the patient that failed, it's the treatment that failed the patient. We're not kicking you out of care. We need to regroup and find something that may work better for you because this isn't working or this isn't safe. And so it may not be popular, they may not agree with you, but we need to try to keep our patients alive and in systems of care that are hopefully the most appropriate. Patients can stay in care for as long as they need. We don't kick anyone out, but we ask patients to commit to 6 months in the beginning, and then if they want to do a taper or what have you, we'll help them do that. They can taper sooner if they choose, but that's just what we do. But every patient is different, and we try to individualize treatment. This is not a miracle drug. It's a tool, and we need to use all the tools we have because we don't have a whole lot of tools out there. This is a clinical pathway that I developed, which kind of just walks through what I just spoke about. And if anyone, again, wants copies of this, I'm happy to send these through to you. So we treat the whole person in individualizing the care. This is just a study that I just want to just quickly show you. This is a study that Dan Alford and myself and my colleagues were involved in, and this looked at 5 years of treating patients in an office-based practice using nurse care managers. So the nurse care managers were seeing patients. The prescribers were treating an average of 35 patients at a time. There was a clinic director, nurse, coordinator, and physicians that were all waivered. The nurses went through a one-day training similar to what the BUP 101 training is for docs, but this was more concrete service, how to deal with the day-to-day stuff. The nurses learned all the types of things that I just spoke about, and they learned how to take care of these patients in an office-based practice, collaborating with their physicians, and how to manage the insurance issues, which are always an issue. So with this, so the patients had to commit to at least 6 months. We looked at how patients did. We looked at medically supervised withdrawal. We looked at transfers to methadone maintenance, and we looked at discharges for non-adherence or behavior issues. We saw that the patients that did better were those that were older, those that were employed, and believe it or not, those that were using illicit buprenorphine prior to engaging in treatment, whereas those that were African American and Latino actually struggled a little bit more, not very much more, but a little bit more, so a population we definitely need to address. We looked at our urine screens, and we saw that patients that stayed in care at 12 months, that 95% of them were opioid negative and cocaine negative. So the longer someone stayed in care, the better somebody did. Obviously, everybody didn't stay in care. 51% were successful in staying in care at 12 months. And we had another 6% that transferred to methadone. So using the nurse care manager model was an effective way to increase treatment, to get more patients into office-based treatment for their opioid dependence, and allowed the physicians to manage a complex group of patients with the supports of a nurse care manager. So we're looking to expand access and treatment with buprenorphine, creating models such as this, and increasing the numbers of physicians that are waivered is the way to go about this. We want to focus more on high-risk individuals and pregnant women. We're seeing lots and lots of pregnant women now, and collect more data to look at treatment efficacy and how to sustain the project. This just shows you when we started these projects in the community health centers, the amounts of physicians. We only had like 22 physicians that were waivered at start, and now we're over 140 plus. And the numbers of patients that were able to be treated in the community using nurse care managers. This just shows you the map of where the health centers are across the state that were funded to provide this service. And we looked at, UMass did a study that came out in the Health Affairs that showed that Patients that were in medication-assisted treatment had lower rates of relapse, hospitalizations, and emergency room visits. They were not any more costly than any other treatment. So buprenorphine is an effective treatment that will keep people out of emergency rooms and utilizing services that are costing money and hopefully provide better outcomes. So nurse care managers is a way to expand treatment to more sites, to increase level of education to other providers, and addiction would be a helpful next step. And we need to look at dropout and retention and try to improve our retention rates more, maybe utilizing more multidisciplinary approaches such as this, similar to what HIV care has done for years, and again, outreach more to Hispanic and African Americans. The website, PCSS MAT, is now a provider website that provides lots of services to all of us, to physicians as well as nurses and other level support such as social workers, lots of great tools on there. And this is just some websites and resources on buprenorphine and addiction nurses. The International Society of Addiction Nursing has great resources, as well as our Mass chapter, and my contact information if folks have questions or want additional information following this broadcast. And as Wesley Clark, the director of CSAT, said, if we do nothing, people will die. And I'll just throw this up for a second if anyone has any questions, and I will end there. Thank you for your attention.
Colleen, thank you so much for that informative presentation. You really provided lots of information, and the database studies were terrific to see as well, so congratulations. We do have a little bit of time for questions, and while you're leaving that slide up with your email address, I know that we've had some questions come in about where to get the brochure that you mentioned earlier. So if people could just take note of your email address, colleen.labelle@bmc.org, and your telephone number is there listed there as well, then I know that you said that you would be happy to share that brochure for patients.
Absolutely.
Great. Another question that came in is, what are your thoughts and recommendations of inpatient versus outpatient opioid treatment? I believe, let me just expand my, about inpatient versus opioid detox. So what are your thoughts about that?
I mean, I think it depends on the patient. Some patients really need to go into a supervised, structured setting and just kind of start from the ground. Some people are able to do it in an outpatient setting. I mean, this is not easy. It's not simple to, you know, hand a patient who's struggling with a brain disease that a bottle of a partial agonist that has an opiate in it on their way and expect them to do the right thing when they can take that medication, start, stop it, take it on the, you know, during the week, don't take it on the weekend, you know, get high, and then I don't have to worry, now I have something to manage my withdrawal. So it depends on the person, and some people need a longer treatment to help them, you know, really get going in their recovery.
Right. So I think your point is it's really individualized, and it would be, again, that discussion with the team as well.
Absolutely.
You talked about protocols being in place, and a question came in is, can a nurse order a change in dose based on a protocol, or does the nurse have to talk to the physician for any change in dose?
Well, if you're changing a dose, you're going to need a new prescription, so you would need to speak with a physician. So the physician always has to sign the prescription. So even though the prescription can be faxed, it's a hard copy prescription with a physician's signature on it. So you can have a protocol that talks about dosing, but you're still consulting with the physician, and the physician is signing off on that prescription before that happens.
Could you comment a little bit about any problems with reimbursement? Do patients need to be under a psychiatrist, or can they be under a board-certified addictionologist for insurance purposes? Any comments there?
So insurance is tricky, and it probably depends on where you are and what part of the country. As far as medication goes, it's typically covered by most of the payers. Some may have prior attached to it or higher co-pays, or they may have limit restrictions, which we shouldn't have with parity, but some do. As far as payers, as far as providers go, the different settings that people are situated in change payers. Lots to do with the payers. So I can't totally speak on that. I know federally qualified community health centers are very well situated to make this a really sustainable model, which is why we looked at that. But the private payers, it would be definitely dependent on who their insurance is and what the reimbursement structure looks like. We do it in an academic setting, but we only get a facility charge for the nursing. But again, something that if you're doing a lot of volume like we are is sustainable, and we're able to manage it covering the nurse's salary.
So thank you. You talked in terms of the project where you started to develop nurse case managers in a one-day training. Could you talk more generally in terms of what you see or educational background for the nurses in this role? What kind of foundational education do they have, and then any additional training? And along with that, what do you see in terms of turnover in that position?
Yeah, no, really good questions. We've seen nurses from all levels, some that have absolutely no addiction experience, and those that have had addiction experience have their CAR and their certification in addiction nursing, some bachelor level, some diploma level. It's been kind of all over the map as far as who we're seeing. There are definitely, in the community health centers, we see more of a turnover, and I kind of think the health centers typically have a large turnover, so I don't know that it's based on this. Nurses really enjoy doing this work, but some of the settings that they may be in may not be the venue that they're looking for. So that might be some of why that's happening. Community health centers, we don't just have turnovers of the nurses, but also physicians is a great turnover. Whereas in our program here at BMC, in an academic medical center, we don't have a large turnover at all. But it is hard. We have developed a huge addiction nurse group in Massachusetts, which gives the nurses a lot of support, and I think that that's very helpful, as well as email informational list servers. But it definitely is a challenge, and there shouldn't be just one of anybody. There shouldn't be just one doctor prescribing. There shouldn't just be one nurse who knows how to do it. We all need backup and resources if something were to happen.
I'm going to take one more question and then we'll close. Can you address if telemedicine with the physician is okay in Massachusetts once the nurse has seen the patient?
Do we do telemedicine?
Correct.
No.
Okay.
I don't know how that would work, but that's not something that we've done. It's been talked about in our psychiatry component of the program, but not as far as the buprenorphine.
Okay.
I'm not sure what the legalities of that are. Sorry. I can check, but I don't know.
Yeah, and if anybody who's on this webinar might be aware of any programs that are using telemedicine, then that would be good information to submit. There's the listserv for the PCSSO MAT, that, as well as the PCSSO for this program as well. So I want to draw this to a close and let people know that our time is up. I want to thank you for participating in the webinar. Shortly, our participants will receive an email from the American Academy of Addiction Psychiatry that includes a link to an evaluation survey. We would ask you to take a few minutes to access it and provide us your feedback on today's session. The session today was recorded and will be posted on the website of the Physicians Clinical Support System, Opioid Therapies in the Near Future, and that site is www.pcss-o.org. The information can also be found on the INSA website at www.intnsa.org. We do hope that you'll join us for the series with other partners that are on the PCSSO, and again, those can be found at the PCSSO website. Colleen, I just want to end by, again, thanking you for your time and for a very informative presentation, and everyone have a good day and good rest of the week.
Thank you.